Sudhir Manickavel. I'm one of the House Neurotology Fellows, and I'll be talking about autoimmune inner ear disease today. I have no disclosures, and so for my presentation, we'll start with an overview of what autoimmune inner ear disease is, the diagnosis and evaluation of it, medical management, then surgical management, and finally conclusions from everything. So what is autoimmune inner ear disease? It's a rare immune-mediated cause of bilateral sensorineural hearing loss, and it's due to an immune attack on inner ear antigens, which ends up resulting in hearing loss and plus or minus balance issues. Typically, it's classified into two categories. You have primary autoimmune inner ear disease, which is confined to the inner ear, and then you have secondary autoimmune inner ear disease, which is associated with systemic autoimmune diseases like lupus or Cogan syndrome. And so for the historical overview, it was initially described in 1979 by McCabe et al. And he had a cohort of patients that he noticed had bilateral sensorineural hearing loss, but were responsive to steroids. So it was the first time it was described. Then in the 1990s, Harrison Sharp reported that 35% of patients who had suspected autoimmune inner ear disease had antibodies to this heat shock protein 70 that they noticed in bovine inner ear extracts. And then in 1994, Mosecki et al. Correlated this to patients and saw that it was elevated in a lot of patients who had the autoimmune inner ear disease, and that antibody levels correlated to disease response to steroids. And then the heat shock protein 70 is, it's in all living cells. It's a molecular chaperone that's involved in protein synthesis and all that. And then in the 2000s, we've been doing multiple studies trying to really figure out what the pathophysiology of the disease is, what's involved, as well as various treatment options being explored, such as methotrexate, how much do steroids help, and even biologics are being explored now. And so for incidence and demographics, the incidence of autoimmune inner ear disease, it accounts for less than 1% of sensorineural hearing loss cases. So it's pretty rare. It's estimated that it's less than 5 people per 100,000 annually, but it can affect up to 15 to 30% of patients with systemic autoimmune diseases. As you can see in this figure, it doesn't affect the autoimmune diseases equally. You see it in some cases more than others, such as in rheumatoid arthritis or relapsing polychondritis, versus you don't really see it in things like ulcerative colitis or Hashimoto's thyroiditis. And typical patient profile are adults aged 20 to 60 years old with a slight female predominance. And so for clinical presentation, patients typically have rapidly progressive, often bilateral or asymmetric sensorineural hearing loss, and it develops over weeks to months. Hearing may fluctuate and is often steroid responsive, and patients may also have tinnitus, oral fullness, and you can see vestibular symptoms in up to 79% of these patients. And it may also be the first manifestation of systemic autoimmune disorder in 25% of patients, so something to keep in mind when you do see it. The diagnosis is still primarily clinical. It remains a diagnosis of exclusion. There's really no gold standard test or diagnostic criteria. It's confirmed by a combination of history, audiometric patterns, and response to immunosuppressive therapies. In terms of the audiologic criteria, you'll typically see bilateral or rapidly progressive sensorineural hearing loss. Often it can be asymmetric, and you may also see fluctuating hearing thresholds on serial audiograms. Then Rausch et al. Described this audiometric criteria back in the 90s, where they described it as bilateral sensorineural hearing loss of at least 30 dB at any frequency, and then evidence of progression, which they defined as greater than 10 dB decline at 2 or more frequencies, or a 15 dB or more decline at 1 frequency over a period of less than 3 months. And then you may also see that the speech discrimination scores deteriorate rapidly. So next, we'll talk about the pathophysiology and kind of what we know so far. So we know that the disease itself is an immune attack on inner ear structures, and it results in inflammation, microvascular injury, and it can disrupt the ionic balance within the inner ear. And there's a combination of cell-mediated and humoral immunity that's involved. The inner ear is thought to be immune privileged. It has a blood labyrinth barrier, and there are resident macrophages, mast cells, and lymphocytes that all kind of help maintain this blood labyrinth barrier and are involved in this immune dysregulation. And so the macrophages, typically you find them in the stria vascularis and medalis, but you also have these perivascular macrophages that help modulate the blood labyrinth barrier. And kind of as we talked about before, you can see other immune cells within the inner ear, including mast cells and lymphocytes. So we'll talk about the cell-mediated immunity first. So typically you will have an infiltration of autoreactive T cells, typically Th1 and Th17 CD4 positive cells that invade the cochlea. And they're believed to invade the cochlea through the spiral medullary venules and end up infiltrating the scala tympani. And this is typically guided by the ICAM1 expression on cells. Once the T cells are within the cochlea or inner ear, they will have they'll release IL-17 and interferon gamma and promote inflammation. Then the mechanism of inflammation, you'll have molecular mimicry and antigen presentation, and interestingly, re-exposure of the inner ear to antigens triggers upregulation of a different cytokine, IL-1 beta, and this ends up resulting in recruitment of additional leukocytes and this results in sustaining the autoimmune process. For humoral immunity, IgG has been detected in perilymph, which suggests a breach of the immune privilege, a breach of that blood labyrinth barrier. And once it's in the inner ear, the IgG forms immune complexes with its antigens, and this results in activation of the complement pathway. The complement pathway then causes more inflammation, increased vascular permeability, so more T cells, B cells, leukocytes all can enter, and then further cochlear and inner ear damage. Some common antibodies that you can see are ANA. This is typically positive in only 50% of patients with autoimmune inner ear disease when they have, just that primary autoimmune inner ear disease, but you can see it in up to 90% of patients that have that secondary autoimmune inner ear disease when they have a systemic autoimmune process also. Heat shock protein 70, which we talked about a little bit. Antibodies are present about 33% of patients with idiopathic sensorineural hearing loss, and is slightly higher in patients that are thought to really have that autoimmune inner ear disease. Matsuka et al. Found that it had limited diagnostic utility and doesn't really confirm if a patient has it or not, but it has been shown that it has some predictive value for corticosteroid responsiveness. So patients who have this protein tend to respond to steroids better than those that don't. And there are also some inner ear specific antibodies, such as beta-tecterin, detected in a subset of patients. Patients who are positive for these antibodies tend to be negative for the heat shock protein 70. And then with all the immune cells invading the inner ear structures, multiple different cytokines are released. We kind of touched on IL-1 beta. This is released by macrophages and helps modulate innate non-specific immunity and helps to activate T cells and promotes Th1 polarization. It can also result in activating T helper cells and B cells. So it does play multiple roles, and you can find it in fibrocytes of spiral ligament, and it increases with trauma. And then Pathik et al. In 2011 showed that increased IL-1 beta in patients with autoimmune inner ear disease tended to be more resistant to steroid treatment than those that had lower levels of IL-1 beta. TNF alpha is another common cytokine that we'll see. It's from infiltrating systemic cells, and it recruits additional inflammatory cells, promotes vasoconstriction within the cochlear blood vessels. It can increase oxidative stress, and there's some studies showing that it may result in synaptic degeneration of some of the inner ear structures. And interestingly, they saw that if you import, or that it's important in adaptive immune response in the endolymphatic sac in animal models. So it seems to be playing an important role in all of this. And then due to the combination of cytokines, cell humoral immunity and cell-mediated immunity, you tend to have vascular inflammation within the blood vessels that supply the inner ear structures. And this ends up leading to endothelial damage, which then results in increase of microthrombosis within the vessels and decreased blood flow and ischemia. You may also see immune-mediated vasculitis. You'll have the immune complex deposition and T-cell mediated inflammation of some of these vessels, and this results in vasculitis affecting the microvasculature. So, summary of the pathophysiology: you have T-cell mediated inflammation, autoantibodies, and immune complex deposition, which activates the complement pathway. And then combination of those two results in vascular injury. Key sites that tend to be affected are the stria vascularis, the medalis, and the spiral ligament. And combination of all of this leads to immune dysregulation and leads to the fluctuating or progressive sensory hearing loss and the other symptoms such as the vestibular symptoms. And so for treatment, steroids are still the mainstay of treatment, but there's also steroid-sparing therapies that more research is being done. And then it's been shown that early treatment, ideally within 3 months, significantly improves the chances of hearing recovery for these patients with autoimmune inner ear disease. So steroids typically prescribed at 60 to 80 milligrams per day of prednisone. Patients initially have or 44 to 71% of patients initially respond well, but this responsiveness declines over time, with less than 14% of patients responding to steroids by 34 months. Long-term remission is rare, but can happen, and tapering is usually required, sometimes over months. Problem is, we can't keep our patients on steroids for a long time due to all the many side effects, especially on high-dose steroids. So sometimes we give them intratympanic steroids. Typically, it's methylprednisolone or dexamethasone, typically used in oral steroid intolerant patients or patients that are not responding to steroids anymore. Benefits are there are fewer systemic effects and possibly higher perilymph concentrations, but that may be debatable. And you do see hearing improvement in 50 to 69% of patients, and majority of patients have good vestibular symptom relief. So next, I'll touch on steroid-sparing therapies. We'll start with methotrexate. So methotrexate is a folate antagonist. It ends up inhibiting dihydrofolate reductase, which suppresses DNA synthesis. And that's kind of how it provides its immunosuppressive effects. Again, it's a steroid-sparing agent. It's used in a variety of autoimmune conditions. And it's typically administered orally with doses ranging from 7.5 to 20 milligrams per week. A study by Harris et al. In 2003 was a randomized control trial with 67 patients, and all the patients were steroid responsive, and they really were trying to figure out what the efficacy of methotrexate was. And so they had two groups, a methotrexate group and a placebo group. The methotrexate group got 15 to 20 milligrams of the medication per week. Well, the placebo group did not, and then both groups received an 18-week prednisone taper. And what they saw was that there was no significant difference in hearing improvement or hearing maintenance between the methotrexate and the placebo groups. So overall, didn't seem like methotrexate is an effective steroid-sparing medication for maintaining hearing improvement in autoimmune inner ear disease patients, especially ones that were steroid responsive. Next, we'll touch on azathioprine. And so azathioprine is a purine analog that interferes with DNA synthesis, which is how it causes its immunosuppression effects. Again, used in autoimmune diseases, it acts as a steroid-sparing agent again. And again, it's given typically orally, and it with doses ranging from 1 to 2 milligrams per kilogram per day. So a study by Mata Castro et al. In 2018 was a longitudinal observational descriptive study where they had 20 patients that were diagnosed with immune-mediated hearing loss, and patients received azathioprine as a monotherapy over 12 months. And what they saw was that patients ended up having pretty good hearing stability over time. There's no statistically different change with the PTA between baseline, which is around 36 dBs versus 45 dBs at 1 year of treatment, indicating that these patients maintained their hearing thresholds and they didn't get worse. They also looked at relapse rates, and what they saw was that initially patients before treatment were having about 2 relapses per year when they were treated with steroids alone, but in this azathioprine, after they started azathioprine, patients had dropped down to about 0.5 relapses per year. So it does increase the amount of times that they end up relapsing. And then we also look at time to audiometric free relapse. And prior to azathioprine treatment, patients were relapsing about every 5 months for those on just corticosteroids, but this increased to about 9 to 10 months after azathioprine treatment. So azathioprine is a good medication in maintaining hearing thresholds and reducing the relapse frequency and rate for these patients. Next, we'll touch on rituximab. And so rituximab is one of the biologics. It targets CD20 on B cells. This ends up leading to B cell depletion. It reduces antibody production, all helping in immunosuppressive responses. And so in terms of autoimmune inner ear disease, typically it's for patients that are refractory to corticosteroids and refractory to conventional immunosuppressive therapies, such as azathioprine. It's typically administered as an intravenous infusion, and dosing regimens vary based on the clinical protocols. A study by Cohen et al. In 2011, which was an open label pilot study with 7 patients with autoimmune inner ear disease, got rituximab, and they really looked at, did this help these patients in terms of their hearing improvement or word recognition improvement? And what they saw was that only 5 out of 7 patients met their primary endpoint, which was an improvement in their pure tone average by at least 10 dB, or a word recognition score that improved by at least 12% at 24 weeks. And so 5 out of 7 patients is pretty good, but it is a very small sample size. And they did see that there were no significant adverse events because of rituximab in these patients. So there may be some efficacy of rituximab in autoimmune inner ear disease, but further studies are definitely warranted to really figure out if it's helping these patients. Another study by Matsuka et al. In 2013 was a retrospective analysis of 47 patients diagnosed with autoimmune inner ear disease. And out of the 47, 5 of these patients were treated with rituximab. And what they saw here was that all 5 of these patients had significant improvement in symptoms like vertigo, tinnitus, oral fullness, but only 2 out of 5 of these patients showed improvement in observed hearing thresholds, but even that improvement wasn't significant. So this study is indicating that rituximab may be better to alleviate vestibular symptoms and the other symptoms of autoimmune inner ear disease, but may not be the best in terms of the hearing loss for these patients. So again, something to keep in mind. So overall, rituximab shows some promise in improving vestibular symptoms, seems to have limited impact on hearing restoration, but we definitely need more extensive studies to confirm the efficacy. And, more randomized trials to establish the definitive benefits and determine the optimal patient selection as well. But maybe in the future, it can be a medication that we use as a steroid-sparing agent that may be useful in refractory autoimmune inner ear disease cases in the optimal patients. Next, we'll touch on TNF alpha inhibitors. So TNF alpha inhibitors, such as their name, they block TNF alpha, which ends up reducing cochlear inflammation and immune-mediated damage, and also helps prevent cytokine-induced apoptosis of inner ear cells. Again, typically used for patients refractory to steroids or to help taper steroids, and patients that are refractory to conventional immunosuppressive therapies. There are multiple different TNF alpha inhibitors. A couple systemic options are etanercept, which is subcutaneous, and infliximab, which is intravenous, and then adalimumab, which is again subcutaneous. There are some intratympanic formulations. Really, it's just golimumab that's been used in some studies. So we'll talk about three of them: etanercept, infliximab, and golimumab, and we'll start with etanercept. And so with etanercept, a study by Cohen et al. In 2005, which was a randomized placebo-controlled trial with 20 patients with autoimmune inner ear disease that were all steroid responsive, received a etanercept dosage of 25 milligrams subcutaneously weekly for about 8 weeks. And what they saw was that only one patient in each group met the primary endpoint in terms of hearing improvement. And so there's really no difference between the placebo group and the group that got the etanercept. And so etanercept was not more effective than placebo, and the study population didn't benefit from it. So it doesn't seem like it's a great medication for these patients. The next one, infliximab, a study by Van Rijik in 2006, was a prospective pilot trial with 9 patients that were steroid responsive with autoimmune inner ear disease. And these patients received weekly intratympanic infliximab injections for 4 weeks via microwick. And they had 2 groups. They had group A, which was steroid dependent, and group B, which was patients that relapsed post-steroid taper. And what they saw was that group A, 4 out of 5 patients that were steroid dependent were successfully tapered off the steroids, and they ended up having stable hearing thresholds throughout the study. Well, in group B, 3 out of 4 patients showed audiologic improvement, with a pure tone average that improved about 22.6 dB, which was comparable to what the steroids helped improve. And additionally, what they saw was there's a decrease in the recurrence rate over time. So it went from 0.84 events per week to about 0.02 events per month. So infliximab via microwick seems to be a safe and potentially effective treatment for patients with steroid responsive autoimmune inner ear disease. It may help reduce the steroid burden and relapse rate over time. And another study for infliximab by Liu et al. In 2011 was a retrospective analysis of 8 patients with autoimmune inner ear disease. These patients, unlike the previous study, were unresponsive to steroids and other immune suppressants. And what they saw was that there was no objective hearing improved, and only 1 patient reported subjective improvement after the treatment. And so infliximab may not be effective for all patients with autoimmune inner ear disease. It may work better with those that are steroid responsive than those are unresponsive to steroids. But further research is needed to really identify who are the responders, who are not, and whether if it's only, the steroid responsiveness that is playing a role in terms of they'll respond to infliximab or not. The next one, golimumab, was a study by Dearberry et al. In 2014, done actually at House. It was an open label clinical trial, and they had 10 patients with steroid-dependent autoimmune inner ear disease. And these patients received intratympanic golimumab on days 0, 7, 21, and 35. and they had a concurrent oral prednisone taper, and they were followed with serial audiograms on days 42, 72, and 117. What they saw was that 7 out of the 10 patients completed the study. Throughout the study, 5 had stable pure tone thresholds, 4 had stable word recognition, and 2 actually showed improved word recognition, and all 7 patients were weaned off of steroids. They also saw there were no serious adverse events, but 1 patient did have progression of hearing loss in 1 ear. So overall, intratympanic appears to be safe and potentially effective for maintaining hearing in steroid-responsive autoimmune inner ear disease patients, and may help support steroid tapering in long-standing disease and decrease the steroid burden on these patients. So overall, for TNF-alpha inhibitors, etanercept doesn't seem to really benefit patients over placebo in a controlled trial for steroid-responsive autoimmune inner ear disease patients. Infliximab did a little bit better. It improved hearing stability and reduced the relapse rate in steroid-responsive patients in a prospective trial, but patients who weren't responsive to steroids and were refractory to other immunosuppressive therapies didn't really have any significant hearing improvement, but that was a retrospective study. And then golimumab was well tolerated and seemed to provide some hearing stability and help to successfully taper steroids in patients that had the steroid-dependent autoimmune inner ear disease. So TNF-alpha inhibitors may be a good option for these patients with autoimmune inner ear disease, but you should be individualized and really, at least for now, figure out if patients are responsive or non-responders to steroids, because that may help us pick one of these medications. But more robust clinical trials are still necessary to establish its efficacy and compared to placebo. Last, we'll talk about anakinra. So anakinra is a IL-1 receptor blocker, and it suppresses the downstream inflammatory signaling to reduce cochlear immune activation and overall inner ear immune activation. And again, it's indicating patients that are refractory to steroids, and particularly in patients with autoinflammatory etiology that don't respond to other immunosuppressive therapies. Typically, it's given as a subcutaneous injection, but daily dosing is typically required, so it's a little more involved on the patient side. A study by Van Butis et al. In 2014 was a phase 1/2 single center open label trial that had 10 patients that had steroid resistant sensorineural hearing loss with at least a 30 dB drop at 1 frequency, and thought to be due to autoimmune inner ear disease. And these patients received 100 milligram subcutaneous daily dosing of anakinra for 84 days, and they were followed for 180 days. And 7 out of 10 patients showed hearing improvement either with their pure tone average or their word recognition score. And the 7 patients who they described as responders had a 12 dB improvement, while the 3 patients that didn't respond only had about a 3 dB improvement. In terms of the word recognition score, the responders had a 28% improvement, while only 6%, or there's only a 6% improvement in the non-responders. Interestingly, what they saw was that patients that were treated with the anakinra that were responders had lower IL-1 beta levels after treatment. And then once treatment was stopped, the patients that relapsed ended up having higher IL-1 beta levels. So anakinra did lead to significant hearing improvement in most patients, and that IL-1 beta suppression may be a viable treatment target in autoimmune inner ear disease. It may be something to be looked at, since it seems to be involved in responding versus relapse. And so for surgical management, cochlear implantation is kind of the mainstay. It's indicated in profound sensorineural hearing loss that's unresponsive to treatment. Outcomes are favorable in autoimmune mediated hearing loss, and early referrals recommended once hearing becomes non-serviceable. A study by Aftab et al. In 2010, which was a retrospective chart review that compared 10 patients with autoimmune inner ear disease versus 12 patients without autoimmune inner ear disease, saw that there's comparable speech recognition scores in patients with the disease compared to the general population. But what they noticed intraoperatively is 5 out of 10 of these patients did have cochlear fibrosis or ossification, and 2 of them required drill out. But even then, these patients still seem to have similar device performance to the general population, and there wasn't any increase in complication rates. And so autoimmune inner ear disease seems to benefit patients, or CI seems to benefit patients with autoimmune inner ear disease similar to those without. An early CI intervention may help mitigate the fibrosis-related complications, at least intraoperatively. Another study by Wang et al. In 2010 compared 10 patients with autoimmune inner ear disease to age and sex matched controls without autoimmune inner ear disease, and they saw there was significant improvement post-implantation in both groups, and the outcomes in the autoimmune inner ear disease group were comparable to the control group. And there was no difference in complication rates. So again, cochlear implantation seems to be safe and effective in autoimmune inner ear disease. And in this study, some of these patients did have systemic variants like Cogan syndrome. So it seems to help patients with systemic or that secondary autoimmune inner ear disease as well. A third study by Ituro et al. In 2022 was another retrospective study where they had 31 patients with autoimmune inner ear disease and 31 controls. And what they saw was that these patients with autoimmune inner ear disease did have good short-term and long-term results, with sentence recognition being 94% in the short term for patients with autoimmune inner ear disease, and long-term in patients with autoimmune inner ear disease with the sentence recognition being 96.8%. But they saw there was impedance fluctuations observed over time, and that there was increased impedance in autoimmune inner ear disease patients versus control for the length of the study, but that despite these variations, there was that satisfactory auditory performance in the long term and short term. And so this kind of emphasizes the importance of post-operative monitoring, that maybe these patients with autoimmune inner ear disease may need, at least initially, be followed a little bit closer due to these impedance fluctuations. But overall, it seems like cochlear implants are still effective. They still get good sentence recognition in the long term, but they just may need a little closer follow-up initially. And then another study by Li et al., which was a systematic review with 29 studies with a total of 115 patients. And what they saw was 114 out of 115 of these patients showed hearing improvement after cochlear implantation with showed improvement with cochlear implantation, and that over time, 1/3 showed continued improvement, 1/3 improved, then plateaued after about a year, and then 1/3 remained stable. And so overall, these patients seem to get good outcomes with it. They also saw that in the studies that kind of described the intraoperative findings, 23 out of 43 patients had unilateral or bilateral fibrosis or ossification of the cochlea. But wound complication rates were the same as the general population, which was a concern due to the high steroid use in these patients. So they're worried that there may be increased wound complications. And so overall, CI is effective and is a safe and effective treatment for autoimmune inner ear disease. So in summary, cochlear implantations have been consistently effective in autoimmune inner ear disease, either the primary or secondary forms. There's no increased risk of perioperative complications across the studies. Most patients showed auditory improvement, and 1/3 patients showed continued gains over time. But we do just have to keep in mind that some of these patients will have fibrosis and ossification, which is more common in delayed cases, and so early implantation is preferred. And that they may need to be followed up closer due to the impedance fluctuations. And then so CI should be strongly considered in patients with autoimmune hearing loss, and early intervention is better for these patients. So, in conclusion, autoimmune inner ear disease involves progressive sensory hearing loss. The progression may vary among individuals and whether it's primary or secondary autoimmune inner ear disease. Both cellular and humoral immunity are involved, and diagnosis is a challenge as there's no gold standard criteria or test, and so early detection is crucial for effective treatment. For medical therapy, steroids are still the gold standard, but there's some promise with steroid-sparing medications, and some of them can be effective. Just further studies are needed to really figure out which ones are the best and, you know, are different ones better for different patients. And that cochlear implants are effective when implemented at the right time, and earlier intervention is better. That is my presentation. Thank you for your time.